Okay. All right. I'm here and oh, it's not even 10 yet.
FYI, you do have a third student.
Oh, I love it. That's so cute.
Your baby's so pretty.
Thank you.
I know. Well, I love your shirt. That's for
Oh
sure.
yeah, it's Bernie.
Bernie. Hindsight is 2020. Yeah, no.
You look good to just have a baby.
Oh, thank you. It's the lighting.
Oh, guys, I turned the recording on. Is that all right?
Sure.
Okay.
Well, you
Because
know,
I
have
was
to watch
thinking,
most
no,
of that.
it's you know, you asked me what muscles did I throw out my back, and it's like I know all this stuff, right? And it's, you know, it should make some sense, but it's really hard when you have to analyze yourself. It was just one of those sneezers. But I was sneezing and it went out. It was like one of those. And you know,
My
it's
cousin
funny.
did it. She was making her bed on Saturday morning and she threw her back out.
Yeah, it's like the last. And is it fascia that's yanking? You know, these
I'm
are the
not
things
sure
that
with
go through my
her.
head, right? I mean,
Yeah.
and I work on these all day long with people, right? And I
Mhm.
help and fix these problems. But it's still such a mystery because fascia, for example, we didn't study fascia in medicine until the 2000s.
Oh, wow.
Yeah, the first Harvard Congress on fascia was in 2007, where they brought it back into medicine. They yanked it out of Grey's Anatomy in the 1930s because it was too complicated. And then they brought it back in the 2000s because they realized it's not just the stuff you're cutting on a cadaver, it's actually doing a lot of good. It's actually very important stuff. And so now they're doing a lot of research on that, and a lot of pain syndromes are happening in those places that we didn't even think about. You know, so so that's why a lot of times, even when it's my own back function, bringing back function is the key. Looking which muscles, like you talk about the massage therapist works your muscles, like bringing back those, looking at all those elements. That's what I do. I look at the bony connections. I'm like, which bones are off? What is going on with that? And I try to mold it. That's where the fascia comes in. Those are all the connections. If you look at a skeleton, it's not just bones. It's all the white stuff that holds everything together. And it's like a tensegrity model, you know, a good old Buckminster Fuller kind of stuff. And so then all the elements, when I see a patient or when you go to a massage therapist, it's like, what are the pieces that are a little bit in trouble? What can we functionally improve? And then the body can take care of the pain versus, and that's also important sometimes, versus figuring out exactly what the problem is and cutting that out. Then that's what we do sort of in medicine. That's why very often we have a little conflict where it's like we have diagnostics in modern medicine and they don't match up, or we can't find anything, and then they're kind of stuck with what's going on, right? And then we get frustrated. But that's the point then when we go and say like, okay, let's look at all the function and think like, what could be not quite working right, and then improve on that. Anyway, we started on I threw my back.
That was good information.
I threw my back out yesterday. That was okay, Grisha?
Yeah, that was good information.
Good. Yeah, you know, over the years, it's like you learn these things and yeah, and I think one of the biggest difference between, or where we can be complementary with each other between sort of Western and Eastern medicine is like understanding that and not thinking one is good, the other one's not, because it's a complementary question, really. Anyway, well, and I don't know which muscles I threw out. But what I do know in German, and I'm sorry, that's why I can't drive today. I can just walk a little bit and do a little things and have lots of medication. So I can't come tonight. And hopefully, usually it eases off in a few days. Hopefully not.
Are you canceling lab tonight?
Yes, I have to cancel lab tonight.
Okay.
Yeah, that's what I actually started with.
Oh,
I wanted to start with. Yeah, and I sent a text out to everybody when I just announced it.
So should we be there Wednesday instead of Monday?
Huh?
Should we be there Wednesday instead of today?
If you can, yes.
Okay, that's good information. I appreciate that. I was going to ask you that.
I'll save you a seat next to me.
Perfect. Wednesday, right? Wednesday.
Good. No, I'm really sorry that I know some people are being inconvenienced, but I try to discern if I can make it or not, and it's just driving and it's not going to work out. And then I just can't sleep all night. And
no, that's fine, because I literally just found out that today was a holiday.
Well, and then that's the other thing. Today's a holiday, although it's not one that is celebrated. But I did get a couple of texts from students who were asking if we do have lab tonight. And of course, back then, that was yesterday, I said, yeah, of course we have lab tonight. But I was hobbling down the street this morning. So yeah, and I don't know which muscle fired off. But the interesting thing, if we take away that it is a pain in the butt, is in German, they call this diagnosis the Witcher shot. Like the witch shot you in the back. Like when you get up and it freezes up. And what happens orthopedically speaking, we talked about the spine, right? We talked about the little discs inside the spine, the pillows. And when you look at those discs, inside the disc, there's a gel. And when that gel moves, it stretches fibers at the end of the disc, and that makes a lot of pain for people. And so that's what they call that diagnosis. But it's such a funny thing. In German, it's called an Hexenschuss. And you see it in the pathology books. And I never believed it. I always thought it was just sort of like a saying. But then when it's, in the official pathology book, it's like, oh, that's really a term, really. And that's
but don't if you also
descriptive terms, huh?
Don't if you also disc is going to be like a hernia disc, right? And that will cause like a bulge inside of.
Well, when you look at the discs are the structures between the two vertebrae. And you have a shell that's on the outside that's connected between vertebra and vertebra. That's like a fiberglass type looking thing, like a fiberglass mesh. So in all directions, these fibers are there holding everything together. And on the inside there, you have a gel, like a motor oil kind of feel, almost like Jell-O a little bit. And the outside attachment is, and together they have a little movement, and they make the weight go, they transduce the forces, the shock waves, and they dissipate those. And those outside fibers, they can stretch, and that gives a lot of pain. And they have actually found that acute low back pain, most likely diagnostically, is a stretching and overstretching of one of those discs. Like that kind of a pain. And if you have that, as you said, your family member was doing a sheet or making a bed or something like that, Nina, it happens not unfrequently. And it's one of those things where the acuteness goes like, oh my God, I'm falling to the ground. But it is also one where you see the acuteness doesn't mean it's fully severe. It's just you need to pay attention to it right now. So the body's language is pain. And so when the pain is really in your face, you really just need to pay attention. And that's why short term, it's okay to take your pain away with pain medicine. And sometimes it's very important. Right now I couldn't function without pain meds today. But long term, you're not letting the body speak its language if you always take all the pains away. And then you run into this problem where you mask the pain and you make the problem worse because you keep damaging the tissue, for example. And so that's where that interplay comes in with like pain meds, where, there's a discussion with that. So, it's an interesting topic. I mean, medicine, we were taught one neurological concept is if you have pain, the fiber that sends the pain to the brain competes with the nerve fiber that sends the motion, that the energy that you create when you move a lot, that tells the body where it is in space. It's called proprioception. That energy goes through the same channels into the brain. And it's like a gate. They call it the gate theory. When you move a lot, your pain goes down because that energy is overriding the pain energy. And everything that we do in terms of mitigating pain, not everything, but a lot of things work that way, including spinal cord stimulators work on that concept. But that's also when a kid runs into the wall and hits its forehead, you rub its forehead and say, like, it's okay, and you kiss it. Because that's that energy. By rubbing the skin, you're firing a lot of those nerve fibers off that tell the body what's going on. The pressure fibers, those compete with the pain, and you're mitigating the pain for the kid that way, a little bit neurologically. So it's interesting stuff. It's interesting stuff. Anyway, but let's go to Nino. Well, let's hello everybody. And we were having a question that came up with the hand muscles. And I want to open it though first to everybody else too. Everybody have questions of today's material or last week's material? If not, then let's start with what Nino and I started with, huh? And if so, if you guys have questions, just speak in to as the discussion goes. But I think, yes, perfect. So I think Nino had a question about, let's speak, you speak, Nino.
So my question is around the biceps brachii and the brachialis. And I've watched the video that on the Radialis Longus and the ulnaris, but I can't figure out on here which muscles these are. I thought this one from here all the way down was maybe the long head of the biceps brachii, which I know isn't in the list of terms. And but I also thought this was maybe the short head. But I'm thinking that.
Can you zoom that?
Because this looks like this ends. Is this the shaft of the humerus? Because if so, then this is the brachialis. So I'm really.
Now, can you zoom that in, or let me go to my end? Let me share.
Oh, sure.
But so no, that's a good picture there. You see the picture here? So everybody, so we have. And then we can look into my material afterwards. But we have this top one is the two bellies of the biceps. So the head length comes from up here. One that goes right to the coracoid process is the short head, actually.
This is the coracoid process.
That is the coracoid right here, yeah. Oh, sorry, yeah, you guys don't see my arrow. You have to do the arrow. I'm pointing this off, but you guys can't see it.
I mean, selfishly, it teaches me where I have to say.
Oh, that's fine. That's fine. So that's the coracoid process. We're bringing that head down. That's the short head of the biceps, and then where it goes distally into the elbow, into the arm, that is going to be the. Oh no, the peasants. I forgot the name of that term. I have to look that up. But that goes where it goes into the fascia, and then it goes into the ulna. All right, that's part of where the biceps feeds in. But then the other part where the biceps really feeds in, the biceps brachii, if you go to the other side, to the other muscle, the bone, there, right there underneath, it goes underneath that other muscle and anchors right there underneath into the tubercle of the radius.
Okay, I'm gonna let you
can't
share.
see that. We're gonna show that on the picture, okay?
Okay, I'm gonna stop sharing.
Yeah, stop sharing. That's the orientation. So at least you guys see it there. And then let me share. Oh, I'm a little slow. Sorry. How do I best get into this thing? Okay, here we go. I'm a little loopy. I am sorry about that. Although I'm probably always a little loopy. We don't need to see my finances. That's my department here. Let's go to bio 2. Sorry about this. Where is my bio 2? Here's bio 2. What chapter is this? I forgot. Chapter 11 or Nina, you know? Lower.
It's 12.
Why can't I see it?
So we go up second from the left in that middle row. Oh, you have it less than 12 as well.
Oh, it's a different thing. Oh crap.
Okay.
All right, sorry guys. I'm sorry. I am a little slow to. It's the upper extremities, right? It's 10 actually. It's 10. It's going to be 10. Here we go. 10 and then there we go. PowerPoint. We just need to see some pictures. There we go. They're coming up. Okay. Le forearm. All the other stuff was all right. Nina, or everybody else.
What's that?
We can go back to all the other stuff too afterwards. Oh, that's the forearm. That's not the upper arm. Do I have here's a picture of the upper arm. That's kind of the picture, right? More or less. So that's the biceps brachii here. And then that's where it goes into here. See that underneath? It feeds underneath. That's what you see. It's except the deltoid and all that is taken off. And so when we go into the muscle itself, the muscle page, I have it. Gosh, where's my biceps? Here's my biceps. I have my biceps right here, and you see here the attachment is the coracoid here, and then this part goes all the way actually to the inside of the shoulder here, and then they come together as these two bellies, and then the main attachment really is not this band that you can see on the picture that is the superficial picture kind of thing, but it's really when you look at it, it goes deep underneath here. That's the main attachment, goes underneath here into the radial tuberosity.
Okay, so in the
photograph
diagram that we're coloring, the deltoid is removed, and I think it's the brachialis is covering the insertion point of the bicep brachii.
Yeah, down in here, right. So
Yeah.
you can only, so you can't see that part. But that's
Okay.
it goes on. That's the part of the challenging things about this anatomy thing. It's layered, right? So, but that's the biceps brachii. And then when you look below that, underneath that, we have the brachialis. And I don't know why this doesn't show me anything. It's a little slow here. So the biceps brachii and then the brachialis. It should show me pictures here. There it goes. It's a little slow. So the brachialis attaches mid-shaft humerus and then goes down and goes into the ulna on the front side there. So that's an underneath muscle. So you see the brachialis here is blue, and then on top of that is the biceps laying there. So it's those two muscles that make a bulk up of the strength of the flexion of the forearm. That makes sense?
Yes. Yeah.
And that makes sense, right? And actually, if you want to go deeper into the biomechanics, what's interesting is you can say that you see that this muscle crosses one joint. So this is purely working on the flexion of the forearm. This muscle actually crosses two joints. So it's also going to help a little bit bringing the whole humerus upward, forward, flexioning, bring it up in the front, not just the elbow. Does that make sense?
Yes.
Okay.
Can
So
you
that's
remind
sort of
me-
biomechanically how you work with it. So it's not flexing the shoulder as a main mover. It just helps with that, right? But it does help a little bit. Yes, Nina?
Just one quick reminder about the hand. The thumb is 1, the pinky is 5.
Yes.
Okay.
What else? Oh, and then the other thing that is always interesting with the biceps brachii is the fact that when you are pronated, when you have your palm down, this is pronated, it crosses over, the ulna and the radius cross over. That's when the biceps brachii comes, and where it's attached at that tubercle of the radius, and it pulls on it and it turns it backwards and straightens it out and supinates the wrist that way. Can you visualize that? No?
Yeah, I can.
Okay,
But
good. Well, yeah, everybody who can speak up, okay? Because that's an interesting feature of the biceps that it really does. And I mean, clinically speaking, obviously it gets interesting if somebody has supination problems, that we look at that, of course, as one of the culprits. But clinically speaking, the muscle that's actually really powerful in that pronation supination department is the Pronator Teres. Did you got I talked about that, and God, this system is so slow. Let me see what the heck is wrong with me. Let me cancel something here. That might help. The Pronator Teres is attached at the inside part of the elbow, the medial side, and then crosses over to the radius. And it is that one that pulls it over and pronates, the opposite motion of the biceps brachii when it supinates it. So we always have, the muscles always does a motion, and then you have a muscle that does the opposite motion. So that's a given in terms of looking at the system, because muscle can only contract and they cannot lengthen actively. But this is a muscle that's really powerfully involved in typing, because when you type, your palm is down. And the thing is that it continuously is contracting, continuously is used in people who type a lot and have the palm down. And the thing is, the median nerve goes through that muscle and pierces through it. And when this is always tight, it squeezes that nerve and it gives you feelings of numbness in the wrist, and gives you carpal tunnel syndrome feelings. And so that's clinically a very, very important muscle that we are looking at in this chapter. Because a lot of people have carpal tunnel syndrome, and a lot of times in the old days, we would go, because that same nerve then travels here through the wrist with all the tendons of the bones, of the muscles that go to the fingers. And it gets crowded, because when you type, you move the fingers a lot. And when it gets inflamed, everything expands a little bit, and you have a finite space, and so it squeezes on the nerve. And so medically speaking, what we used to do surgically, we cut that open and make room in here. But of course, that is it didn't always work. And when it didn't work, we found out that we have more problems in this muscle, for example, or also in the scalenes. We talked about the scalenes in the axial skeleton up in the neck, in the front of the neck. And we've learned to, also look at those areas when somebody comes in with wrist numbness and wrist pain, carpal tunnel syndrome. And so the more you know about that, the better, I think, in terms of, that's one of those, I consider being an office computer work person is a sport. Is a high-end sport. You have to look at because you have some areas that just burn out if you don't watch them. And that's one of those areas that people get trouble with if they have a little, they have a little weakness, their proclivity already or something, and then they do it for years or decades, and it really wears out. Anyway, that was my little rant. Where are we at here? Did you want to talk about the finger muscles, Nina, or? Hello, are you here? Yeah. How's everybody doing? You guys okay?
Yeah, I'm okay.
Oh, okay, good. I don't know if I had mine on silent or something. Did that make sense, what I just talked about? No?
Pardon, would you repeat your question?
Did that make sense, what I was just talking about? I'm just trying to find a segue to where we're at. If we answered your questions with the biceps, the brachialis.
The biceps, yes. The last 2 minutes, unfortunately, I missed. I had to pick up a phone call, and so I had to unmute.
That's
so
right.
That's
okay,
why.
that's right. Yeah. I just talked a little bit about the pronator. So because it kind of goes together with the biceps in some ways. But from there, anybody have any more questions on that material? On the upper extremities? Did you want to talk a little bit about the hand? Are you okay with that, Nina?
I would love it. I would love it. I mean, I'm going through the coloring now, and they're pretty hard, the hands.
Yeah.
So if you don't mind just doing it again, that's great.
Do you want to go through it with the homework in this or
that would be awesome.
On the lecturing? So let me lecture, and then how about this? I lecture and then a little bit on it, the front ones, my spiel, and then we go through your homework. All right. Good. So let me do that. So the forearm muscles, and I'm sure that's always a challenge because this is a tough one. The forearm muscles in the or you know, the whole forearm muscles are pretty layered and intricate because what happens there is you're moving the wrist and you're also moving the fingers through the muscles that are in the forearm, and you're doing the most of the movement into a flexion movement, into a bending of the finger movement, and all of those muscles are in the front part pretty much. Well, no, those pretty much are. That's actually all of them. And then you have muscles that do the extension to straighten the fingers out, and also bending the wrist over and backwards, and those are on the top portion in the dorsal part of the forearm. So the big meat of the muscle, if you feel it, is really the front, and you have to grab things. So those muscles have to be much stronger. So when I look at those muscles, I am mighty slow still today. Here we go. When I look at those muscles, I'm interested in our class to go. We're looking at the first layer, and then we have more layers to it. So that's one thing we need to know with those. And it's not like we're not going deep enough. We're going plenty of deep. But the more superficial muscles will move the more proximal things. The more superficial muscles here on top will move the wrist stuff around, and the deeper the muscles go, the more into the tips of the finger we get in terms of movement. So we're not really we're not really studying the muscles that move the fingers, that flex the fingers. We're mostly looking at the first layer that flexes the wrist. And so when we look at that, and then a couple other ones, when we look at them, superficial ones, we got 4 of them. So we got 2 that flex the wrist. So these are called Flexor Carpi. So the ones that do that, you can see them on the pictures. They usually go the Flexor Carpi, one of the ulnaris, one is ulnaris, one is radialis. So one goes towards the ulna and one goes towards the radius. And the one that goes towards the ulna, that is towards the pinky. Unfortunately, the pinky is cut off right down here. But the ulna and pinky go together. So the Flexor Carpi ulnaris is a most medial muscle in these pictures that goes to the wrist on the pinky side. And then we got a Flexor Carpi radialis here, and that muscle is a bit more lateral to the outside, but it sort of points. If you look at where he points, you look at the tendon, you go down the tendon and see where he points, and he points towards the thumb. This is the thumb side. I know, I'm sorry, that one it's cut off, but that's where the thumb is. I should have left that a little bit bigger, maybe. It's hard to do these pictures all right, I tell you, spatially speaking. And then, so we have those 2 that work on the wrist. And then we got 2 other ones. We got one muscle that's very superficial that's between those 2 wrist flexors. It's called the Palmaris Longus. And it's a very interesting one. It's very superficial. If you actually hold your wrist like that, you can see it sticking out here a little bit. You can sort of feel it. That tendon, the top tendon, is that muscle, and it goes into the palm, into the web of the palm, and it pulls on the palm like as a whole, like as this kind of. That's the Palmaris Longus. So I like the term Palmaris. At least that helps me. Terminology, actually, the muscles is not that bad. The flexor means some function. Carpi is where it goes to the carpals, and it's on the ulnar side. So that's kind of helping you with your direction. You know, you're looking at finding a street thing, and you're looking at landmarks, and so and at hints. And so that's the hinting there. And the Palmaris Longus, the hinting is it goes into the palm of the hand. And then the last one we have there is the one I just talked briefly about before, which is the Pronator Teres. And the Pronator Teres goes pretty much across from the ulna to the radius. And what it does, it pronates the wrist, or the palm. So we know the word again tells us what it does. It pronates it. And teres, I forgot what teres means. I think it means triangle or something like that, but don't beg me on that. So that gives us 4 muscles that go from the ulnar side on the front of the forearm down towards different attachment points, or over and then down. And so they are Pronator Teres, Flexor Carpi Radialis, Palmaris Longus, and Flexor Carpi Ulnaris. They all have the same attachment site. They start at the, actually, they don't start at the ulna. They actually start higher up at the humerus, but on the ulna side, at the medial epicondyle. That's that bump. If you feel that bump right here where you hit the funny bone, that's not so funny. That's that place. That's where they attach. So they come from there and underneath in there, and they move. Sorry, I can't show you. And they move forward this way on the front arm. And so what we can do is we can take, this is a right arm, a right forearm, and we can, this I learned this in Cairo school, how to remember them. You have a right forearm and you put the web of the palm, the other side, into that medial epicondyle, and you put your fingers across, one down towards the thumb, one down towards the middle of the wrist, and one to the pinky. And those are your 4 muscle alignments. I'm sorry. As in Pronator Teres, the first one, Flexor Carpi Radialis, the one that goes to the thumb, Palmaris Longus, so palm goes to the palm, and then the Flexor Carpi Ulnaris that goes to the pinky. All right, so that's that one. If we look at that puppy in situ, so to speak, in the situation, we have the medial epicondyle right here. We got one muscle that goes sort of down, the most proximal one, a little over. This looks a little bit less going quite diagonal. So you got anatomy is always a little different with everybody. So, but that is so you're looking at where it goes to. That's one place where you can figure out what is going on, and you're also, you know, have a ballpark thing. You orient.
What does proximal mean again?
Closer towards the shoulder, closer towards the attachment of the body, like proximal, distal. Like proximal is closer towards the attachment of the appendage, which is the shoulder, or the arm is the shoulder. And we use proximal and distal really only in the extremities, when we describe things in the extremities. So here, this is the pronator teres. So you have the medial epicondyle here, and so if you put you take your other hand and you put it on that site, and you put the fingers down, you have that first one is that pronator teres. Then we go down towards the thumb, and you see how that goes into the wrist right here, and that's the Flexor Carpi Radialis right in here. And then you jump one over, and you see here's the Palmaris Longus, because it goes right into the palm. You see how this tendon goes right into the palm, like in here, and then it can pull on that whole palm a little bit. So it's not a strong muscle. Actually, 10% of the people don't have that muscle. So you know, if you don't have it, I guess you don't have to study it. I don't know. And then the last one here on the outside is the Flexor Carpi Ulnaris, and that goes to the pinky side of the. We can't see where it attaches in, but it attaches here in one of the carpals, and this attaches to one of the carpals here. So those are the forearm muscles. And see, you got other ones too, deeper ones. You got Flexor Palmaris Longus, you got Flexor Digitorum, Superficialis, etc., etc. Those do more, they're deeper. We'll do those next semester. But they're basically, these move mostly the wrist area around, and then the deeper ones start moving the finger joints around. And then when we can go to the hand, and we got like 4 layers of muscle in the hand. And it's quite crazy in there too. It's very interesting, but it's, you know, don't, if it feels like it's complicated, it is complicated. So don't, you know, be okay, a little bit okay with that. So, but from there, that's why I have a system of how to kind of look at it, because it gets overwhelming. And so do you guys, does that sound okay, how I explained it?
Yes.
Do you want to share the homework, Nina, and go through that real quick?
Say that one more time.
Do you want to share your homework and go through those terms real quick?
Sure.
Are you feeling all right with where we're at?
I'm a little occupied.
Oh, then never mind. If anybody else wants to show the homework and we can solve it, then that's cool. But otherwise, let me just then go to the other side, the back side of the forearm, and finish with that in the discussion. My system is still slow. Too much stuff. That's okay. Come on. That's mighty slow. There we go. So these.
By the way, Teres means rounded or polished or smooth.
Okay. Huh. Thank you.
Mm-hmm.
I wonder how that applies. But I'm sure there's some reason why they called it that. There's most of the time there is a reason why they call something, even though it's very silly. And there's some consistency. So let me open this. It's a little slow here. Still, I'm so sorry. So when I look at the backside, really, I kind of have a mirror of the front side, but the backside is not as powerful. So like, or not as needs to be as powerful. So like we don't have, for example, a Palmaris Longus at all in the backside, or whatever they will call that, a dorsalis thing or something. But what we do have there, we still have the wrist flexors. Now they're just extensors. So instead of bending the wrist this way, now they bend the wrist backwards.
I think your screen might be frozen because I'm only seeing slide 30 on the left-hand side really small.
Yeah, I don't see it either. I'm waiting for it to fill in. I'm not sure why it's so weak. There it is. My system, something is really pulling a lot of energy from it, but I can't figure out. Usually it's Chrome, but it's not.
Do you have like 50 windows open?
Not that many, about 20. I try to close them before class. I have, let me see real quick. Well, anyway, we got it here now, right? So we got on the extensor side, so this is the back side. So you can see it looks a little bit different, but here instead of having a Palmaris Longus, what you have one on top that goes all the way to the fingers. So you have that right there superficially. On the front side, that is covered up. So we didn't study that on the front side. So on the back side, we study that. We have an Extensor Digitorum on the back side. The front side has a Flexor Digitorum, actually a superficial and a Profundus. Profundus means profound, that means deep, right? So a superficial and a deeper one. But on the backside, we only have one. So one of the ones we study is the Extensor Digitorum. And then the other two I think we're studying 3 on the backside. Is that correct? Yeah. The other 2 we're study are the extensors carpi, the ones that bring the wrist back. Instead of flexion, they extend. So instead of called flexor now, they're called extensors. And they're still called carpi because they're bringing the wrist joint back. And here they're still having radialis in it because this is the one that points to the wrist. I mean, the thumb side of the wrist. And as you can see here, you actually have 2 of them. You have a longus, a brevis, extensor carpi radialis brevis, and extensor carpi radialis longus. See here, the longus, it starts up here and goes all the way down. And then the brevis starts here and it goes all the way down. And you can't see where it exactly goes because you got so gazillion many tendons there. That's why you want to know from where to where, right? And that way you can kind of find your map around most of these anatomy pictures. I'm only going to worry about you learning the extensor carpi radialis longus and brevis as a unit. And so the one muscle that we study that's on the outside, that goes from the outside down to the thumb side on the wrist with the tendon, that would be the extensor carpi radialis, brevis and longus, or, you leave the brevis longus out, that's also okay. They only have to put brevis and longus because there's, 2 heads of it, basically. Again, the naming, in some ways, the naming is arbitrary because the muscle just creates muscle where it needs the forces. And then the other thing here is the extensor muscle that's interesting to know, its common attachment is the external, the lateral epicondyle, more or less. So as we look at a common origin for those, they all sort of come, instead of from the inside of the elbow going over to the front, they now come from the outside going over to the top through the fingers there. And that's what that's called. The Extensor Digitorum is the second one here. So the Carpi radialis and the Extensor Digitorum, and you can just see that how the tendons go all the way down into the finger joints. So that's where you can recognize that that's what you're talking about. You're talking about the finger joints, the digits. And then the last one that we're worried about, the forearm, is the extensor carpi ulnaris. And that's next to it. And you can see here, this is a nice one because you can see the tendon go clearly right there to the wrist bone and not all the way down to the fingers. So that's where you can see that differentiation. All right. Good. How was that?
You'll resend the video, right?
Yeah.
Yeah.
Absolutely. I'm actually recording. Thank God I didn't forget that. Today, anything is possible. Got it a little bit. All right, then any other questions to that? Was that last week? Like that was last week, and then this week we're sort of looking at the lower. So we're gonna be back in class on Wednesday.
Will we be going over all this stuff?
Yeah, we can. Absolutely. So we're layering. I think the repetition in different formats is really the key. And I tell you, you know, the more you know, the more you understand this level. Functionally speaking, in the world of pain and stuff, that's all you really need to know. I mean, it's really, you know, it's really detailed enough, or be able to reference back, or be able to say like, hey, this is going on with me. Yeah, I got that frozen shoulder. So what did the massage therapy work? Which is, then it's interesting. Then you know something is what's going on with me is not a mystery, you know.
Mm-hmm.
And so from that perspective, the level of muscle detail that we're doing for most of what we're dealing with is plentiful, you know. And I clinically, I teach it the way I look at it clinically. Like I look at which muscles move to anchor the shoulder to the trunk, which muscles move the arm around, which muscles bring the shoulder and hold it into the shoulder blade. You know, then when you go and see like what happened to me, why am I hurting here? Then you can start thinking about it versus like, oh, I threw a ball and it just went out. Like, well, who's doing the throwing of the ball motion, for example? You can start deducing. Not that you have to do that, but it's that process taken further. It's the same process. And if you are already putting some pieces together when somebody works on you or you have a problem, then you can look it up. Then you are part of the discussion of what we're doing about it. And that's really one of the main points of the whole thing, I think. That makes sense?
Mm-hmm.
Sure. All right, let's then just, if you guys are doing pretty okay with all of that, we can just go through see what we're doing this week. Oh, look at that. That's my nutrition class that I'm taking. Let me go to this week. Everybody's very quiet. You okay, you guys? Everybody else? Yeah? All right. No feedback means good news. So this is what we did last week. We started a little bit on the injury prevention eval, so just work your way through that this week too. If something hurts, don't do it. Or talk to me, or, you know, depends on your background with knowing how your body works. Just don't overdo it. But I like the injury prevention thing because it is what what we do clinically, you know, and what they do for the Swiss Olympics, even, for example, in Switzerland, where they test everybody on these kind of things like squats and things, and see how, if there's weaknesses in those channels or if the muscle's too tight, and then we'll work on that to not get injured. And so that's why I want you guys to do that. But we did that. We started that last week, and then this week we're starting to go here through the lower extremities. And the lower extremities are pretty similar to the upper extremities in many aspects. We got a hip, we got a femur, an upper thigh bone, you know, it's a femur instead of a humerus. Then we got two lower leg bones, and then we got feet stuff going on. What motions we need? Here is the question when I look at then the musculature, and when I look at the hip level, I look at one motion that goes on in the hip is turning the foot outward. So the external rotation of the foot happens actually at this level up here. And when I go deeper in that discussion and see let me pull back let me, hold on, let me do something real quick. Because if I pull back up one of those PowerPoints and then it's so slow, it drives me crazy. YouTube probably, let me cancel everything else that I thought is not needed to be canceled. Okay, that's not. Okay, let's see if that makes a better impression then. Okay. We're on 11, right? Chapter 11 here. All right, so I'm pulling that out while I introduce it, and I'm going to pull it up in the app so that way hopefully it goes faster. Okay, so let me go through then. So we're looking at the hip motion stuff. When I look at the hip, what happens up in the hip motion, then now I can share this, sorry, and then I'm proper. I started looking at the PowerPoint, but you guys need to be seeing it. There you go. Now you see the PowerPoint. That's good stuff. So when I look at the hip joint area, what do I have? I have a few motions that I want to take place there that I need to do with the hip. One of them is turning the foot outward or externally rotate or laterally rotate the whole thigh and leg, and of course the foot as well. That's where we see it. That happens up in the hip, and those muscles are attached sort of here medially in the back part and then go out into the femur to pull on that femur backwards. We have multiples of those. The ones we talk about is the piriformis up here is the main one. Then we also have motion on the hip that's a abduction. Abduction is pulling the hip outward, bringing it to the outside. And that muscle group that does that is sort of attached here-ish, and then also in the front a little bit. So we're looking at the gluteal musculature and the tensor fascia lata. The gluteal musculature are sort of our butt muscles. We have a few of them. We have the gluteus maximus, that's the superficial one that's attached on the sacrum, and then it goes over to the crest a little. And then when we look at the whole attachment here, it goes into the gluteal tuberosity, what that's called here, but it also feeds into, and I don't know why this picture doesn't show it, it actually also feeds into the IT band, iliotibial tract. If you see this picture here, you see how the back comes in and it anchors here, but it also goes into this band here, into this iliotibial tract band. And so when you figure out this will contract and it pulls on this band, it kind of pinks the leg outward as in abduction. And the same is for a muscle in the front of the hip. So everything attached here, and then this one, this tensor fascia lata attached in the front of the hip also pulls on this iliotibial band and pulls it outward. This IT band is as flat, it's like a flat tendon, and you can feel it on yourself. If you go onto the outside of the thigh and you rub your finger across it, you probably feel a little flatness there, a little of that band. So that's a motion that we're looking at in the hip, and then we go further down into the gluteus. We have the maximus here, and then the lower in one we have a medius, and we even have a minimus of those muscles. And let me see where those are described. Oh, they are still described there. This is actually a really nice picture here where the minimus here is the big. So if you're looking at the big bulk of the butt muscle on the outside, you're looking at the gluteus medius. The maximus is sort of a thinner one on the back. The medius is a really cool muscle because it attaches here and then it goes into the greater trochanter right here. And what it does is when you walk and you lift the one leg, that muscle on the opposite side, the glute medius, contracts so your hip stays level and doesn't fall down with gravity. And so that's a very, very big function that gluteus medius has. Probably the biggest one. That's why it's pretty bulky, and you see it in walkers and hikers. It gets very strong. And then the gluteus medius muscle is one that's just deep inside underneath it and has a similar function. It also is a little bit more on the front, so it also can do a little bit more flexion motion, bring the thigh forward a little bit. But that's minimal. That's not really anything to worry about. The thing that's really cool to understand and remember about the gluteus medius is the fact that it helps you not waddle, helps you stay upright when you walk. I think that's kind of the coolest thing there. And then the other thing the hip needs to be able to do, so it's got to be going out, it's going to be going back in. If you bring it out, you got to bring it back in. And so the back in muscles, where are those muscles? They're the adductor muscles. See here, we talk about, this is the TFL. So these muscles here bring it out, the TFL and the glutes. And then we need muscles here, the adductor groups. They attach from the inside, from the mostly actually from the front, and also, no, both from the front pubic bone and also from the sit bone, as we see, and they go to the inside of the thigh, or actually to the linea aspera, really the backside. But they what they do is they bring the thigh, they pull the thigh inward, they bring the leg inward, and so they do that adduction. So they're called, as a group, they're called adductors, not abductors. Where are the adductors? There they are. I don't know. I put them that far down. Here we go. We got a whole bunch of them. But what's interesting is they're really massive. Some go to the front, to the pubic bone, and then the big one, some also go to the back. So you got like these two fans that make sure that, because what these muscles do, they stabilize the muscles medially. So if you're running sideways, zigzag, these muscles have to stabilize that the bones, they pull the right way. And one of my patients I had was Christian McCaffrey, and he's one of the big stars now at the NFL. I had him when he was the star at Stanford, and it was very interesting to be. And he's known, he's not a big guy, and he zigzags. He's like really a cool player, and he zigzags through these people with the ball, and his adductors were so strong. It's incredible. So that's what that does. And then so we have the legs going out, the thighs. So that's the motion at the hip. They're bringing it back in. We rotated the foot out. We did that. Now we got to be able to bring the leg forward. We have to bring the leg forward, and then we have to bring it back and extend it. So the forward motion is done by muscles. Wait a minute. Here, that are attached on the front of the spine, and also also a little bit of the iliac fossa here. And then they go to the inner part of the thigh, into the lesser trochanter, it's called, that little bump right inside. You can, if you push on that, if I work on that on people, it hurts. So it's a very small place, but has a lot of muscle attachment, so it pulls really heavily. And what that muscle does to these two muscles, these are the Ilio Psoas muscles, psoas and iliacus together. They call them Ilio Psoas, and they pull and they bring that thigh forward. They bring it this way when they pull. They flex the thigh. That is, if you want to stretch, a lot of people. I had a patient, an ex-student actually, and he had really sharp back pain. And actually, I think that's what's going on with my back too, in part. I work this muscle like heavy. He was a young kid, so I can go for it for like, I don't know, 20 minutes maybe. Really, every little trigger point, every little tweak in there, I stretched it out, and I worked and I squeezed the blood out of it, and I made the muscle go through lengthening while I squeeze it, and do all that work on all of that. His pain, he said, was 96% better a couple days later, still, and it seems like it held. So that was a very interesting situation. And so the psoas, this muscle, gives a lot of back pain because when we sit, it is always shortened. And so this is also the muscle when you drive a long time in a car and you're one of these people that get out and have to stretch out slowly. That muscle is what's tight and what's been holding tight, and it takes a little time to elongate it and let it go. So that's a very walking, what is that called when you walk like that, long and stretch it out and feel this muscle on the inside in the groin. That's a very good thing to do. Lunges, that's called a lunge. That's what it is, lunges. So that's the muscle group that brings the thigh up, and now we got to bring some to bring it back to the back. And actually, that's where we bring them back to glutes, because the backwards is not as, so we have the glute max that really pulls on that and brings it back. So that's extension, hip extension. A glute max is a big one on that. So then we bring the hip back down. And so that's what we do on the hip. And then we're going to go to the knee. After that, motions that muscles are here usually happens at the knee joint. So the muscle is usually more higher on the attachment side, more proximal, so to speak, and works on the joint that's more distal, that's further away. But if proximal distal is still a little bit of a challenge, don't get stuck on that. That's, it's sort of self-explanatory when you think about it, that the muscles here in the thigh will move the joints here because they have to pull on these things that are, you know, further away from the attachment of the trunk. Anyway, the knee, what the knee mainly does is it bends and it straightens out. So we have two big groups that we want to worry about. We have the hamstrings in the back. They flex the knee, they bend the knee. This is how you can stretch them out. This is a big portion. If this is too tight, you get a lot of energy and pain from here. Tightness pulls into the back and yanks on here and gives back pain. So these are big players in a lot of injury stuff. So that's the hamstring. So they flex, they bend the knee. And then the quadricep group, which is the big, massive muscle in the front of the thigh that goes through the patella into the front of the tip of the knee, really where you kneel on when you kneel. And that's the quadricep group. And those do that motions and go through those. Those muscles are massive. Those muscles actually, the vastus means big. Those biggest muscles, Vastus Lateralis and Vastus Medialis, they start at the linea aspera in the back and reach around to the front of the thigh. And that's how big they are. And then we got two more. Quad means four, right? Quad means four. So quadricep means four. So we have those two. And then we got one that's deep on the bone and goes into this tendon called the Vastus intermedius. This one here. These are the trigger point charts. So if somebody has these pains, you can see these X's. That's when you squeeze the blood out of these X's, you've got a good likelihood that this pain diminishes. So if you're good with your hands massaging, go for it on your friends, on your family, if they let you, because it's good stuff. Because I think one of my experiences over the years is that, and you know, especially with the kids too, you know, keep them in that energy that it's that they feel that, because if a lot of us dissociate from our body, if it's because we're in the phone all the time, or because we don't have abuse, or because we have trauma of what kind, physical, emotional, etc., we're leaving the body more and more. And I talked to a lot of psychologists over time about that. You know, bringing ourselves back into our body awareness is a very, very, and pain too. Pain is a very big function of like, oh, we want to escape, and bringing that body awareness back in. And that, if, especially family and friends, we could do that with each other a little bit, maybe more family, depending, then that's great, because the more of the body awareness we have, the more, the richer our life, I think, is, but also the better we can deal with things like the pain and things like that. Anyway, I don't know. So that's it. And then in terms of the knee motion, I think what I need to talk about, and then the rest is ankle. And in the ankle, again, or the calf, we're looking at the calf stuff for motion at the ankle. And down here we have, again, the big motion we need to do is push it down and lift it up. So we push down the ankle, we plant our flex, and then we bring it up, we dorsiflex. And that's an important thing in walking. So we got some massive muscles that are able to push the toes down, or actually are able to lift the heel up. This is what these in the back do. They lift the heel up, the calcaneus. The big one there is the gastrocnemius, or the tricepsura, which is the gastrocnemius, and then one that's below it. So you see here, the gastrocnemius goes from the heel, the calcaneus, to the femur. Then below that, we have one that lays there on the tibia and the fibula and goes into it. That's really a strong muscle, and that's called the soleus. And it's called because it looks like some fish, but I'm not so sure how that looks. But that's the resemblance that they thought. But the soleus is a very important blood supply thing. So if you don't contract that soleus, you start getting pooling of blood more down in here, because the return of the blood back to the heart happens by going through, the veins go a lot through muscles, and by muscle contraction, they get squeezed and the blood gets pushed towards the heart. And so when this muscle doesn't contract, let's say you do a long flight in the airplane, or people at the guard watching the Queen's coffin, they stand there for hours. And did you see that in the news? One of them keeled over. And that's because the blood supply back to the brain is diminished because gravity pulls it down and they don't use their muscles. So very often they do like push their toes down into the ground to contract that muscle, even though you can't see a movement. They contract it isometrically. So they're holding it and releasing it, holding it to pump that blood up into the brain. So that's kind of a cool thing to know. Very powerful muscles. They have to lift a whole weight up on one foot. Think about that. That's a lot of weight for one little small muscle. And then when we go deeper into that's the superficial layer of the back calf, and then there's muscles in the deeper layer. And when we go deeper in the calf, we go and look at compartments. And I look at 3 compartments, 3 areas. And they're actually delineated by thick bands that go between like the fibula and the tibia. There's a very thick membrane, inner osseous membrane, they call it. And that, for example, separates this from the behind, the anterior compartment from the posterior compartment. And then we got one more on the side right behind the fibula. And so the muscles they call it compartments because they're really enclosed. And some people, like basketball players, often get these compartment syndromes where the muscle cannot relax and it pushes out against fascia that surrounds these muscles and holds these muscles in place. And the muscle, it can get necrotic. I mean, it can die. I mean, it's not cool stuff. It's powerful stuff. But medically speaking, what we do is we then cut through the membrane that hold the compartments together and give the muscle some room to breathe. The problem with that, the muscle pushing out against these compartments exudes a third or something about there of the force of the muscle contraction. And if you cut that membrane, you lose that amount of muscle strength. And so when you have a professional athlete, that is a very, very bad thing. Oh, I mean, the muscle dying is worse, of course, but we want to see different methodologies to help with that if we can. And my teacher's been helping with a lot of them. My teacher was the Utah Jazz doctor, chiropractic doctor for 30 years. And so he had a lot of that stuff and he helped it differently. It was very interesting, learning that kind of stuff. I didn't expect that. But anyway, that's where those compartments come in. So the front compartment is the one in the front here. And that mainly, when we think about what it does, it brings the toes up. It lifts the toes up. So we have a few muscles in there that we study. We have the one that's right by the bone. It's the tibialis anterior. I want you to study that mainly, all right, as the test goes. The other ones are cool too, though. We have the side one here. You see this picture is cool because you can see how you have one that goes all the way to the toes. They call that the Extensor Digitorum. The longest, there's a brevis inside the foot. And then we have one that goes here, the purpley comes out in between the two and goes to the big toe. And that's called the extensor hallucis. The word hallucis means big toe. So that's the anterior compartment. Then we got a posterior compartment somewhere. And in the posterior compartment, it's very similar. We got, instead of bringing the toes up, we push them down into the ground. So we have a muscle that's in the between, and that for here is the tibialis anterior. And that goes to the ankle and pulls the ankle up. And then we got the one that goes to the toe. Here it's called flexor, not extensor, or digits, sorry, the digits. And then we got one that goes to the toe. And they pull the toes and the digits down, or the big toe and the pinky toes down, the little toes down. What's interesting about that, what's confusing about that, and you don't need to remember that, but just if you come across, go like, that doesn't make sense. It's like that hallucis, the big toe, starts on the outside where it's the pinky side, and it crosses over to it. And so that's kind of goofy. Let's see if we can see that. So that's kind of crazy how that goes. And so the other one is on the other side. The digitorum starts on the other side, and it moves over to the pinky. So there's like a crossing. See, there's like a crossing. Like here, you see the tendons. You see the tendons in here. That's why I put this picture up. You don't need a very, about that. But if you come across and you go like, that don't make any sense, then that's why it don't make any sense. All right. I think that's it for, and then the lateral compartment. So we have to bring the wrist, bringing it up, and pushing the toes, bringing the toes up, pushing the toes down. And then we got one more end on the side, the lateral compartment. And those are the ones that go underneath the foot. It's really interesting. They go underneath the foot and they help the foot from, we twist your ankle. They help the foot they prevent the foot from twisting that way. And so that's a very interesting muscle that kind of helps pull the foot laterally so we don't twist it internal. And so when we twist the ankle a lot, these muscles get really stiff and tight. And so they're really overworked. And so we have to work on those, for example, if that's the case. But that's an interesting muscle end too, because the foot has the tendency, when we look at walking, it has a tendency to fall outward. And so that's why we have that extra muscle group out there. All right, you guys. So that's it for today that I have. And we look at, we have to finish up real quick with, with the exercises this week, the activities this week. I'm sorry, it gets a little bit more into detail, but I hope you guys are okay with some of that knowledge. You can always stop me. If you're bored, you stop me. But look, this week we have, they're on week 8 now. But week 8, we basically have a discussion. Let me see. We didn't talk about joining the group. We can talk about that next time. We'll take that out right now. And we have a labeling of the lower extremities. So you guys keep going with those things. And I think we should be okay then. And if you have any questions, you reach me. If you have any questions right now, if you have any questions, I know I went overboard. If I don't hear, that means no. So then I will hear from you. Text me if you have anything coming up. And if not, I'll see some of you guys on Wednesday. There's no class today. And we'll keep going. Have a wonderful, wonderful week. Take care. Bye.